So today we are going to talk about Breast Cancer Awareness Month. It's October. And if you would please introduce yourself.
Sure. My name is Gallaty. I am a fellowship trained breast surgeon. I am now working with the Center for Cancer and Blood Disorders.
Okay. And I believe how we got a hold of you was through Texas Health. Mansfield Hospital, which is being built here. They have a relationship with you guys. So anyway, so I wanted to do a shout out, you know. But I'm gonna just kind of start by asking you a question that's on my mind. What's new? So let's go there. What's new right now?
So breast surgery changes all the time.
Okay.
You know, something today will be different tomorrow. From surgical treatments to chemotherapy, we're getting new regimens and new medications all the time. For me, from a surgical standpoint, we talk a lot about oncoplastics. So what does that mean?
Yes.
Fellowship breast trained surgeons, they train specifically to learn these oncoplastic techniques where we try and do different things in the aesthetic and cosmetic appeal for the patients. So things from hiding scars, you may have heard of the hidden scar technique.
Okay.
We learned that in our training, where we try and limit the visibility of the scar, whether it's putting it in the inframammary fold, which is underneath the breast, around the nipple complex, so to minimize what's there. Okay. That's one technique. The other thing we do in terms of oncoplastics is if we do a breast conservation surgery, also known as a lumpectomy or partial mastectomy, where we only take a piece of the breast out, we do different rearrangements within the breast that's remaining to try and provide as normal a contour of the breast that's there. And then the other technique that a lot of people are hearing about now is what we call either skin sparing or nipple sparing mastectomies. What that means is we take out the breast in its entirety, leaving either the skin with the nipple or just the skin, so the patient still has their own skin and or nipple there for reconstructive purposes.
It's interesting. What pops into my head when you say that is, well, why wouldn't they have done that before?
So it is a long surgery. A regular mastectomy where just the breast is taken off completely, you know, each side can be done within an hour. And these other techniques take a bit longer because, again, you're still hiding the scar, whether it be inframammary or on the side. You're trying to limit the scar that's visible. And you have to take all that breast tissue from kind of like underneath the skin, leaving that in its entirety. So it does take a lot longer, and it's part of our training that we do in our fellowship.
Okay. So I know a little bit previously you and I were talking about the impact of COVID.
Right. So COVID, obviously, it's right here. It's in the news every day. It's been here for the last several months, and it's probably going to be around for a good time to come. Initially, a lot of the hospitals were just shut down in terms of letting people in. With regards to breast care, screening mammograms completely stopped. Both for a safety standpoint from the hospital, and also a lot of patients didn't want to come in. Also regarding surgeries, patients that were already scheduled for cancer cases, they still had their surgeries still being able to be done. However, new cancer diagnoses were taken on a case-by-case basis in terms of the urgency of surgery. There were newly released protocols from the American Society of Breast Surgeons that was quite impressive. They released it within a couple of weeks in how to manage each patient. And a lot of patients were put on what we call neoadjuvant regimens. So neoadjuvant meaning before surgery. So whether it be endocrine therapy, which was just taking a little pill, or chemotherapy before surgery, we took each patient and decided what would be the best option for them to kind of hold them off until it was safe enough to come and have their surgery done. Diagnostic mammograms were still being done. So the diagnostics would be if someone had a mass or something that they felt in their breast or some change, they could still get a mammogram done. Even now, as things have begun to open back up, there are still some patients who fear coming to the hospital because of COVID. And we understand that as physicians and anybody in healthcare, we know the fear that COVID presents to people. We want to let them know that we're taking every measure, and it is important to get back on track to getting your mammograms done, because mammograms are important because they're a screening tool. It's the only screening tool that we have to be able to catch a cancer early. And we have our patients coming in with masks, our technicians have masks on, everything gets cleaned down appropriately. And we just want our patients to know that yes, there is a risk. There's a risk going out anytime at this point, but we're doing the best that we can to have you get back on track with your screening.
Okay. And, we talk about screening. What are, from a preventative, is there anything that can be done to prevent? And that, talking along with that gene, is there, so if you're tested to see if you have that gene, and then what all can be done from a preventative standpoint besides the screening, which I realize that's part of it.
Right. So statistically speaking, the risk of any woman getting breast cancer is about 12.5% in their lifetime.
Okay.
Any person.
Okay.
The two biggest risk factors for getting breast cancer is being female and being above the age of 50 years old. Things that we look at when any patient comes to our office, we look at how long they've been exposed to hormones. So we know breast cancer can be impacted by the amount of estrogen or various hormones in your body. So we look at the age of menses, so when they started their menstrual cycle, if they're in menopause, at what point did they reach menopause? If they've been on any type of hormone replacement therapy and how long they've been on it. Other things that we look at relating to the genes is family history. Who in their family has had breast cancer, but we don't only focus on breast cancer. We look at all cancers, especially pancreatic cancer, colon cancer, prostate cancer, because those are all tied into that infamous BRCA gene that you're relating to. So BRCA used to be, and it still is, the gene that everybody's like, oh, this is breast cancer. However, as genetic testing has evolved, we're finding more and more genes that are also involved or can relate to someone having breast cancer. And so when we see a patient, we look at their family history, and if there are the various cancers involved in their family history, we will refer them to our genetic counselor, and so they can get a more detailed family history and decide what genetic panel would be appropriate to test them for.
Okay.
So we don't only test for BRCA anymore, we test for a wide array of genes. That kind of ties into the multidisciplinary approach that we treat breast cancer with. It's not only anymore the surgeon and just cutting out the cancer or cutting off the breast. We have us, the surgeon, we have medical oncologists, we have radiation oncologists, as I mentioned before, genetic counselors. Nutrition is very important, so we have that as well. The emotional stability of our patients is important as well, so we have psychologists available. It's a whole multidisciplinary, it's a whole dynamic approach to treating a patient with breast cancer.
Right. I'm listening to that call. Oh well.
So other things in terms of prevention, we talked about nutrition. So there's always been a back and forth, don't eat this, don't do that. There's not enough data to show what you should or shouldn't eat. So we always recommend a healthy diet. Green leafy vegetables, low fat, everything in moderation.
Right.
We do know that there's an association with tobacco use and alcohol use, not only specific to breast cancer, but other cancers as well. So we always counsel our patients on that, to either limit their use or quit smoking, and we help them to achieve that as well.
Okay.
Those are kind of the major things. Oh, exercise is very important as well.
So it's the things that you can, that kind of like turn the switch on, right?
Sure.
So you may have that in you, but your lifestyle may determine whether or not you ever get that.
Absolutely.
Because that's what determines whether or not it gets turned on,
It
so
can.
to speak.
It can definitely have an impact.
Okay.
We know that the gene being there
Mhm.
obviously increases your risk,
Right.
but there's always a certain percentage of people that just having that gene, they may never get that cancer, while others will. And then there are
Right.
other people who don't have that gene that still get
That
cancer
get
at a
it.
younger age.
Yeah.
And most likely there still is a gene that they have that's causing them to get a cancer at a younger age. We just haven't identified it yet.
Wow. Okay. So thinking about the future, what do you think is going to happen in the future when it comes to breast cancer?
So obviously screening will always be there.
Right.
Screening for any disease process, breast cancer, your mammographies, colon cancer, your colonoscopies. You know, it's the only way that we can catch things earlier.
Mm-hmm.
The earlier you catch a disease process, the better the outcome will be in terms of treatment and survival.
Mm-hmm.
So I think mammography will always be there.
Mm-hmm.
In terms of breast cancer, at some point, I think we're going to focus, and we're already starting to focus on immunotherapy. So using various immunotherapies, such as antibodies, to treat the cancer. There's going to be,
Really?
we're focusing more on the what we call the biology of the tumor. So that's why we always like to say that breast cancer is an individualized approach. So there are more and more tests being developed where we take a patient that has a cancer, and if they're not responding to the general chemotherapy that's available, the tumor can undergo biology analysis to see if there are different mutations within that specific tumor and find another regimen to target that.
Yeah, it amazes me to me, I think that should be on everything, that it should be custom to the individual.
Mm-hmm.
Otherwise, it's like, well, we'll take this one thing and throw it out there, and it's hit or miss.
Right.
And with the knowledge that you think that we have, that we would be able to really target by the individual, that just makes sense.
Mm-hmm.
So, okay, well, that's good. That's a good thing.
Yeah. And I think that's true for a lot of other cancers as
yeah,
well.
yeah.
You know, the biology of the tumor,
Mm-hmm.
the more and more we're understanding various cancers, therapy will be targeted towards that.
Yeah, makes sense. Even to the DNA of an individual,
Mm-hmm.
understanding what their DNA structure is from the get-go, you can custom, I would think, preventative plans,
Right.
by the individual, if you know those things ahead of time.
And that goes through into the preventative measures as well, as we're speaking about. If we have a patient who has a long family history of cancer, and then we send them to genetic
Mm-hmm.
counselor, and they come up with various genes that can predispose them to breast cancer.
Mm-hmm.
We can do high-risk screening for them, so they can start screening earlier with MRIs and mammograms, and depending on the density of their breast tissue, even ultrasounds.
Right,
So they don't necessarily have to wait until age 40 to start the screening.
right.
So everything we do, we say it's customized to the individual and their concerns and their needs.
Excellent. Thank you very much. I appreciate it.
No problem. Thank you for having me.